Hello, and thank you so much to IBD Journal Club for the invitation to lead today's nutrition topic, Partial Enteral Nutrition and the Medical Nutrition Equity Act. My name is Stacy Collins. I'm a registered dietitian specializing in IBD. I help people with IBD through a virtual online private practice called Roman Well. And fun fact, I'm also a patient. I have a J pouch, so I'm currently on medical leave from post-grad research at the University of Oklahoma Health Sciences Center, where I am researching IBD nutrition. Today's presentation will provide a review of the literature for partial enteral nutrition and Crohn's disease, as well as an opportunity to put today's knowledge into action on behalf of your patients with IBD. We know from research that exclusive enteral nutrition is highly effective at inducing and maintaining remission, including promoting mucosal healing and even histological remission in active Crohn's disease, especially in pediatrics. In this instance, EEN is steroid-sparing and can even be growth-promoting. We also see positive outcomes with EEN and corticosteroids in adults with Crohn's disease. However, the burden of adherence is difficult on patients, and if you'll remember, Emily Haller mentioned food-related quality of life, and patient quality of life is certainly a massive consideration with EEN. Resultantly, both adults and children struggle with the exclusivity factor of EEN. To triage this limitation, PEN has been recommended as a treatment option due to its safety profile. So today we will review the most relevant research literature on the efficacy and the role of PEN in both active and quiescent Crohn's disease. This review highlights 13 studies from 2000 to 2018, some challenges worth highlighting as we will see through today's exploration. There's some inconsistency with dosing, and some patients were on special elimination diets as well, whereas others were not. There seems to be an all-around lack of consistency and certainly a need for larger randomized control trials. If patients were on medications, the only ones studied are highlighted here. The ideal candidate for PEN described through this literature review is someone any age who's non-adherent to EEN or wants to avoid corticosteroids. As an IBD dietitian, however, I would be remiss not to mention the importance of taking the rise of avoidant restrictive food intake disorder into grave consideration, especially given the predisposition for malnutrition, before prescribing PEN to your patients. This was not mentioned in the review, but I do feel ethically responsible to mention it as a very strong consideration. If you're not already screening your patients for ARFID, please do consider referring your patients to IBD specialized dietitians who can support your patients through this sort of screening process and implementation of this sort of intervention if it is nutritionally appropriate for the patient. You'll see here that I highlighted the statistically significant changes that were observed in the literature review. As you'll notice, patients were on various formulas with various doses. However, the statistically significant differences on this page highlight the benefits of PEN compared to the control groups, CG, or non-treatment groups, NT. PEN is effective at both preventing relapse and inducing remission here in the 3 studies that did display statistical significance. Again, paying more attention to these adult studies that are highlighted for statistical significance, we again see discrepancies in the route and even timing of PEN administration. Here we are at least seeing more consistency with formula, although some discrepancies with diet do exist in the data here. Regardless, PEN seems to complement infliximab in regards to maintaining remission rate. In quick summary, PEN is more effective than control groups at inducing and maintaining remission in Crohn's disease, and while this review neglected to mention, access to an IBD dietitian for evaluation and monitoring is absolutely crucial to ensure patient safety throughout the need for PEN intervention should it be warranted. Cost and accessibility are strong considerations, as well as taste fatigue and quality of life. While PEN may be safer and more effective from a quality of life standpoint compared to EEN, we would certainly benefit as a community from more well-designed studies with larger and more diverse sample sizes, seeing PEN as both a monotherapy in very mild patients if appropriate, perhaps even as a bridge for treatment in lieu of steroids, or even as a tool for combination therapy. Again, a very important consideration, especially in regards to medical compliance and adherence, would be accessibility, which brings me to an actionable item to conclude today's quick nutrition discussion, the Medical Nutrition Equity Act. I urge you to contact your local House reps and state senators and ask them for thoughtful consideration of co-sponsorship for the Medical Nutrition Equity Act. This would ensure broader coverage of enteral formulas and less financial burden on patients. Additionally, Insurance is usually more keen to cover more aggressive nutrition support like TPN that actually has a higher hepatic side effect profile than enteral nutrition formulas, even though it's more expensive than enteral nutrition simply because of the PIC line. They apply this logic to EEN or PEN and often deny coverage simply because the nasogastric tube isn't in place, when it usually isn't even necessary to begin with. The Medical Nutrition Equity Act would ensure coverage without NG tube placement. And finally, thank you for letting me spend this time of your day with you. I so appreciate it. Feel free to reach out with questions. I'm happy to discuss them with you. Special thanks to Kelly and Christina, both dietitians that I'm happy to know. Thank you for inviting me to today's IBD Journal Club for Nutrition.